welcome to this high-yield explainer. You know, as medicos, we deal with a lot of complex pathologies day in and day out. But honestly, very few are as insidious as the one we're covering today. We're going to take the epidemiological data and the microscopic pathophysiology of glaucoma and translate all of that into actionable, real-world protocols that will literally help you save your patient's sight.
Okay, let's just jump right in with a pretty staggering statistic. Globally, 50% of people living with glaucoma are completely unaware they even have it. Think about that for a second. Half of your affected patients are walking around right now with progressive nerve death, and they feel absolutely fine.
And this really illustrates the massive stakes of our discussion today. We're talking about over 80 million people affected globally. As the #2 leading cause of blindness worldwide, it causes this silent, creeping, peripheral vision loss. And the absolute most critical clinical takeaway you need to remember? The damage is completely irreversible. Once that vision is lost to optic nerve damage, there's no getting it back.
So here's our clinical roadmap for today's explainer. We'll start with the silent global epidemic, walk through a classic clinical case, break down the anatomy of nerve death, map out the diagnostic matrix, set up a symptom triage dashboard, and finally cover our screening protocols.
All right, part 1, the silent global epidemic, or as it's often called, the quiet death of vision.
The crucial point we have to internalize is captured perfectly right here. There's just no pain and no warning in the vast majority of cases. If you're a clinician waiting for a patient to complain about losing their vision, well, you've waited way too long. By the time a patient actively complains of symptoms, we've already lost the clinical battle. At that point, we've shifted from preserving their sight to merely delaying legal blindness.
Let's move to part 2 and look at a classic clinical case, Mr. Iyer.
Meet Mr. Iyer. He's a 62-year-old retired teacher, got type 2 diabetes and myopia. His chief complaint is actually pretty subtle. He just says he's been bumping into things on his side for the last couple of years. But when we examine him, he presents with massively elevated intraocular pressure. We're talking 32 in the right eye, 28 in the left. And looking at the fundus, we see a really dangerous cup-to-disc ratio of 0.8 bilaterally. Plus, his visual field already shows an arcuate scotoma with a superior nasal step.
Now, Mr. Iyer definitely didn't get to a 0.8 cup-to-disc ratio overnight. This timeline maps out that quiet death of vision. From a normal baseline, patients experience just slight peripheral dimming in years 1 to 3, which then progresses to noticeable blackness in years 4 to 7, and ultimately ends in severe tunnel vision. With untreated elevated IOP, patients are losing about 1 to 2% of their retinal ganglion cells every single year. It is a slow, relentless anatomical destruction.
So you might be wondering, why on earth did he wait 2 whole years to come in? Well, it comes down to a really fascinating neurological phenomenon. The brain actively fills in the missing visual field. This trick is so incredibly effective that it can mask up to 40% of optic nerve loss. That translates to anywhere from 6 to 10 years of silent damage before a functional deficit is actually noticed by the patient.
Okay, section 3, anatomy of nerve death. Let's look under the microscope.
To really grasp this, we need to visualize the whole disease process. Think of the eye almost like a blocked sink. This maps out the direct cause and effect journey from fluid overaccumulation at the front of the eye all the way back to the irreversible structural nerve damage at the rear of the globe.
The mechanism you absolutely need to memorize is this linear cascade. First, the ciliary body produces the fluid, the aqueous humor. Step 2, the primary drain, the trabecular meshwork, gets blocked. Step 3, because fluid is being produced but can't exit, we get an intraocular pressure, or IOP spike. And finally, step 4, that elevated pressure is transmitted entirely to the back of the eye, directly compressing the optic nerve at the lamina cribrosa. This mechanically induces ganglion cell apoptosis. Essentially, fluid dynamics at the front dictates nerve survival at the back.
Moving on to section 4. The diagnostic matrix, covering POAG, PACG, and NTG.
I've synthesized this diagnostic matrix so we can clearly contrast these clinical profiles. On the left, we have primary open-angle glaucoma, or POAG. This is going to be about 70% of your cases. It's the insidious, painless onset with slowly failing drainage and an IOP over 21. In the middle is primary angle closure glaucoma, PACG. This is an acute, physical block, highly prevalent in Asian and Indian populations, and guys, this is a medical emergency. They present with severe pain, colored halos, and they need immediate pilocarpine and IV acetazolamide. And finally, on the right, normal tension glaucoma, or NTG. Don't let a normal pressure fool you here. Their IOP is consistently 21 or lower, but suspected vascular dysregulation causes nerve death anyway, and they actually often present with worse disc hemorrhages.
Next up is Section 5, the Symptom Triage Dashboard, red and yellow flags.
You really have to train your triage staff and tune your own clinical ear to catch these red flag emergencies right away. Halos around lights, sudden severe eye pain accompanied by nausea, or acute blurred vision, these demand immediate assessment to prevent permanent acute damage. But on the flip side, you have to actively probe for the subtle yellow flags. Things like difficulty adapting in the dark because of peripheral fiber loss, or frequent spectacle changes, simply because their fluctuating IOP is subtly shifting their corneal curvature.
Finally, Section 6, screening protocols to actually preserve vision. Look, a simple puff of air is just not going to cut it here. Your clinical arsenal requires the full, comprehensive checklist. You need Goldmann Applanation for a true gold standard pressure reading. You need a dilated fundus exam to properly evaluate that cup-to-disc ratio. You absolutely must use Humphrey Perimetry to map out their functional visual fields. And crucially, you need OCT mapping to measure the retinal nerve fiber layer thickness. You're hunting for that microscopic structural nerve damage before it ever actually affects their functional vision.
The difference in patient outcomes is basically entirely dependent on how proactive your protocols are. If you're waiting around for the patient to notice blurry reading vision, well, you've already missed the window. Central vision is preserved until the very late stages, meaning irreversible functional blindness is already imminent. Conversely, by enforcing annual checks for your high-risk patients, you get early detection of those silent IOP spikes. Immediate intervention at that early stage can preserve 100% of their functional vision.
So, knowing that diabetes, myopia, and being over 50 drastically multiply a patient's risk profile, I want to leave you with a clinical decision for your very next shift. Imagine you have a 55-year-old diabetic patient sitting right in front of you. Their reading vision is perfectly normal. They feel totally fine. When exactly are you going to schedule their next comprehensive eye check? Because honestly, the answer to that question might just be the difference between them keeping their sight or losing it forever.